Good afternoon. May I welcome you to our 84th episode of our COVID webinar series. For health professionals and by health professionals are absolutely the case today. I'm Dr. Claire Bayntun, a clinical consultant in global public health and Vice President of the Royal Society of Medicine. Today we'll be exploring the insights of Professor Hugh Montgomery, offering a health service perspective on ending of the restrictions. It is a particular pleasure to have welcoming Hugh here today to join us, because he was with us on our third episode of this series back on the 9th of April 2020. At that time, we were listening to his views and insights from inside the intensive care unit. We've travelled a journey with this pandemic since then, and if you're interested to go back and see that episode, you can do that on our YouTube playlist. Professor Hugh Montgomery is University College London Professor of Intensive Care Medicine. He's a consultant intensivist and a director of the Research and Innovation at the Whittington Hospital. He is head of the Centre for Human Health and Performance at the UCL Division of Medicine. And importantly, Hugh has a strong leadership portfolio in the arena of climate change. We have had many excellent questions from the audience that have been sent in at the stage of registration, and I look forward to bringing those into this webinar. We also have a live Q&A option for you. Please do kindly upvote the questions that most interest you. So, Hugh, could you please give us an outline of our current status of where we are in terms of cases, admissions to hospital, and indeed mortality?
Well, thank you, Claire. So the data, as you know, are not desperately reliable, partly because in terms of cases, in symptomatic cases, it requires people to present with illness, get swabbed and get a proven diagnosis. And increasingly, it appears that lots of people don't want to be tested or swabbed, partly because it might stop them going on holiday, et cetera, et cetera. But the data we have at the moment are that numbers probably are falling slightly. We're around 27,000 a day of cases, down from somewhere around 36,000 10 days or so ago. That or maybe 61,000 at peak. In terms of admissions, as you'll know, we're not quite sure how it relates with the Delta variant and how it's modified by shingles-shot vaccination. But previously, the median for admissions have been around 5 to 6 days after presentation with diagnosis. And we're getting around somewhere north of 850 admissions a day at the moment, with somewhere between 5,500 and 6,000 hospitalized cases, and around 91 a day dying with that on their death certificate. And of course, there'll be an even greater lag for that if it's within 28 days because the time it takes to die. So that number we can expect to rise even as cases are currently falling. In terms of your likelihood of being admitted if you are proven to be infected, I did the maths again last night, allowing for around a 5.86 day lag between looking at admission date and the likelihood of being swabbed and diagnosed 6 days before, so offsetting those two graphs. And it's been essentially consistent for the last 2 months, that it's around 2% of cases are admitted to hospital. So that's where at the moment, around 25,000, 27,000 cases a day, somewhere approaching 850 admissions a day, somewhere between 5,500 and 6,000 in hospital, north of 90 deaths a day, and around 2% of cases being admitted.
Thank you, Hugh. And I've just come from a meeting with colleagues at PHE, and in fact, they were just confirming there's been a 20% reduction in testing over this very recent period, which tallies to what you were just observing. And absolutely, they do believe that there was a very clear uptick rate resulting in the peak following the Euros, which again was expected. And at the moment, we do have an uptick in hospital admissions and indeed mortality. So we'll have to watch this space. But certainly things have improved perhaps on how they were. Can we ask then about the status of vaccinations?
Yes, well, of course, this brings us into this very gnarly area of policy and what should have been done, what should be happening now, what might happen in the future. And you know, because you and I have spoken about this before, that I had grave concerns about this concept of a freedom day where everything disappeared. To be clear, I don't like the term because it suggests something to do with involuntary imprisonment, and it shouldn't be about this. That should be about a consensual issue of us all behaving sensibly. And the idea that suddenly all limitation and restrictions go away because they were forced upon us and that we now become free and can revert to normal is nonsense. We are not going to revert to what we had before, ever. That is not going to happen. We are not going to go back to where we were 2 years ago. That's not going to happen in my lifetime, I don't think. So the question then comes down, are we adequately protected? Now, what you might say, of course, is if we were all vaccinated and protected, at least those most likely to die, and we prevented transmission, and we were also well vaccinated that we couldn't be infected and brew up some nasty new variant, then I think we'd all agree that would be the time to lift restrictions. I mean, quite clearly, that would be a good time because we can't stay in a lockdown forever with all the consequences that would bring. But what we have done is we've lifted it when a very, very large proportion of our population are not immune or protected. So if you look at anyone under 18, there's hardly any of those have been vaccinated at all, and that's quite a large group of people. You might say that they don't die of infection, and you'd be right. They very, very rarely die of infection, but they do transmit it. We're increasingly seeing that they do get this Pims type syndrome. We're increasingly seeing cases of long COVID, and indeed one of my son's friends has now been off for 4 months with quite clear evidence of long COVID. This isn't some psychological reaction to lockdown. And if you look at adults, we've got to remember that a third, even last night, a third of UK adults, or 28.9% to be precise, have not had 2 doses of the vaccine. And as we can talk about in a second, that's where you get your optimal and still not perfect protection. Remember that 11.7% across the country of UK adults haven't had any vaccine doses at all. So that's more than 1 in 10 adults in Britain has not had any vaccination at all. So I think over the entire population, including children, it's probably north of 50% that aren't protected. So this is going to allow infection to spread. And if you have large numbers, even if the mortality rate is low, large numbers will still mean the total number of deaths could be quite high, let alone the case for long COVID. And quite clear, of course, there are some areas that are much worse than others. So just in preparation for tonight, I looked at my local area for our local hospital, and 40% of our adults haven't had a vaccine dose. So there's obviously great regional disparity here, and some areas are being hit much harder than others, as we've heard from colleagues up in the north of England particularly.
Yeah, Hugh, can I just pick you up on the acronym Pims? We have discussed that within this series, but those are members of our audience that might not be familiar, that post-viral syndrome. Yeah,
so it's an immune response to in children that creates basically a sustained inflammatory response. So it's a pediatric inflammatory mediated syndrome, which can have quite severe consequences. I mean, it can end up with people on intensive care units and so forth. And again, while the overall risk is relatively low, if you have large numbers, then the prevalence becomes much higher.
Yeah, thank you very much. So to go on to actually this impact of Freedom Day and taking it from the perspective of health professionals, we've talked a bit before about the risk of sustained lockdowns. Would you like to just run over those? Yeah, well, the risks to me, sitting from the shop floor, I don't sit in your elevated positions in PHE. The first are, I suppose, within the healthcare system. We know that the lockdowns of healthcare systems have not been good for delivery of healthcare to people that haven't got COVID. It's been very disruptive to care. Patients were scared to come to hospital, so even when we would have welcomed with open arms, they didn't come. Whilst I'm a great fan in some regards of telemedicine and virtual consultations, I'm a bit old, I'm nearly 60, and I still think that seeing someone face to face and laying hands on them has value. Especially in trying to unpick complex symptoms and working out if someone's seriously ill or not. I think that's much harder to do. And we've certainly seen cases where, people's symptoms have been
ascribed to something less sinister than it actually was. So I think we've all been familiar, my colleagues in palliative care are seeing people coming direct to palliative care that would otherwise have had curable disease for cancers, for instance. And my colleagues in cardiology are seeing people presenting with really severe heart failure now because they didn't get picked up with their coronary syndromes and their myocardial infarctions. So we've got a lot of those, let alone those people that I'm of an age where I do know people waiting for hip replacements and knee replacements. And, their lives are utterly miserable with severe intractable pain and immobility because we've not been able to get through those. So I think that's the first element, which has been bad in lockdown. The second will be the health economics, because we're bankrupting a country with COVID. The expenditure has been colossal. The revenue and tax generation has been vastly less. And we already were in trouble with health service funding. And that's not a criticism particularly of any particular government's approach. Internal inflation in the health service has always greatly exceeded inflation nationally because we have more and more technology, more and more we can do, greater and greater expectations, and more older people and far more non-communicable diseases, meaning we've got to treat them. It's going to make that balance of the books very, very much harder in terms of how we sustain a health service. And again, I without going into my own politics, I have some sympathy with government on pay raises. I appreciate that we've all worked very hard and it's been a blistering and horrible year. And I also appreciate I'm on a consultant salary. And if I was on a nursing salary, a junior salary, I would definitely be expecting a greater pay rise. But I do understand the difficulties across a large organization of increasing expenditure enormously when the budget is going to be tight. Then there are the consequences, I suppose, outside in terms of lockdown of the impacts of locking down socially on terms of mental health. And whilst we had some benefits to the lockdowns early on, far less trauma in trauma centres, for instance, people weren't going out getting drunk, crashing cars, falling downstairs and stabbing each other as much. In lockdown one, drug overdoses virtually disappeared because people couldn't get to see their dealers. So there have been some health benefits. We also know that in some areas, smoking rates have gone up. Weight gain has happened. There hasn't been weight loss. And we know that in terms of mental health, there's no one would deny, and I speak personally on this, that this has not been a good thing for any of our mental health. But finally, there's this issue which you'll be familiar with of infectious disease. We rely for coronaviruses, rhinoviruses and others on a sustained background level of infection, which tends to get worse in autumn and winter and then die away in spring and summer. And with immunity that might last, let's say for most native coronaviruses, around 143 days, you need that background level to stop mass transmission. And of course, with a winter, well, with a spring, then an autumn, winter, spring of lockdown, that native and herd immunity to RSV, for instance, and to rhinoviruses and other coronaviruses has all but gone. And so we are already seeing now, as we lift lockdown, significant cases of nasty upper respiratory tract infections. My pediatric colleagues tell me they're seeing a lot of RSV now hitting the wards with croup and wheeze. I have no idea, despite wearing FFP3 masks, how I got mine, but I was laid low for 2 weeks with a horrible virus that was not COVID. It would have been one of the others. So that will come back potentially with a vengeance. And of course, with the lockdown, we haven't been spreading influenza around the world either. And normally we rely on seeing what happens in Australasia to be able to predict what vaccine we should make to protect us. And now we're really flying blind. We don't really know what flu variant we're going to get. And it will be an awful lot more potluck whether a flu vaccine works this winter. And finally, of course, there's the economic impacts of lockdowns. And we know that my world of intensive care is a very, 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 very expensive way of saving lives compared to public health. And a lot of public health problems are driven by health inequality. And a lot of that is driven by poverty. And we have noticed this, of course, with COVID. It's been the poorest and most disenfranchised that have suffered worse. And we may well be driving that further. So it's not that I'm against the concept. I'm not arguing with people who say that lockdowns are bad, because I agree with them. Lockdowns are very bad. It's just a question of trying to achieve the balance of their impacts versus the benefits of protecting people from COVID.
So then, Hugh, I need to ask you, what are the risks of lifting these restrictions from your perspective?
Well, it's difficult. Again, I may be eating humble pie because, again, you know, you and I have had conversations offline, as I have with other colleagues, as we discuss these things, and you'll know that I was vociferous against the lifting of all the restrictions as we saw them recently. I couldn't see any way in which we weren't going to be knocking 100,000 cases a day towards the end of this month. Now, suffice to say that part of it has been a bit of a cheat. As I say, you're telling me 20% reduction in people getting tested. Well, of course, part of that might be because there are 20% fewer people with any symptoms that want testing, but most of our evidence would say that people are avoiding testing. So numbers may be higher than they are. But even so, I'd have to admit they're not where I thought they would be. My concern more was with the whole idea that of this concept of a freedom day. I think it was politically with a small p framed. I think the press like the idea, or some elements of the press like the idea that everyone's been imprisoned, locked up against their will by a punitive state, that now at last we've been freed from our shackles, can move forward. And the problem with a scientifically often ignorant population, and why would they need to be our level of understanding of infectious diseases? It'd be wrong for us to expect otherwise. They need clear guidance. And for me, that clear guidance, if we were lifting restrictions as we've done, would be to say, lift some of them, but really, do we really want people untested packing up bars and nightclubs? Do we really want to say you don't have to wear a mask? And this problem with mixed messaging, I really didn't think was helpful at all, to say on repeated interviews, you don't have to wear a mask, but we anticipate and expect that you will. What does that mean to most people? It's a completely conflicting message. The message, to my mind, should have been, you should still stick to wearing your mask, for instance. You should still stick to meeting outdoors. We should still restrict the density of people inside pubs, clubs, and so forth at the moment, for the fear of the spread that we've got. Because we've got to remember as well that people have been told that vaccination has brought us out of this problem. And it has indeed made a massive difference to mortality. I mean, 3 cheers for the folks at AstraZeneca and Pfizer. Declaration of interest, I consult for AstraZeneca, but all of the vaccine manufacturers, 3 cheers for them. But they're not 100% protective. We know that 2 doses of Pfizer, and it's similar, around 96% effective at preventing mortality, 2 doses of AstraZeneca, about 92%. But people will still die despite double vaccination. And we know that probably 2 doses of vaccine reduce your risk of getting symptomatic COVID by around 2/3. But you and I were talking just before this, we both know plenty of people with 2 doses of vaccine who've been pretty ill with COVID, because it doesn't protect you 100%. In fact, you've still got a 30 to 40% chance of getting the infection that you would have got before. So my personal feeling was that we should have stuck with some of those rules, because once you change them, it's very hard to reinstate them. And I think a lot of people had sort of got the hang of the fact that you just wore a mask on a train or the tube or a bus, and you just sort of shoved your mask on when you went into the supermarket. But now I had to take a train the other day with my son for 4 hours. It was packed solid, standing room only. And we did a head count. 30% of the people on that train were not wearing masks. And those trains are not designed for the sorts of air exchanges that we need to keep people safe in confined positions. So that's where I'll stop on that sort of rant. I think we should be sticking with some of those. I think most of us with common sense, and we can talk about in a minute how we should be behaving inside hospitals. But we know that masks are very, very effective. You know, they will reduce viral load from the person wearing the mask by at least 70%. And we know from the Cambridge data that if you wear an FFP3 mask in a hospital, it could be up to 100% protective. So a combination of surgical mask on your patients and an FFP3 on you really should stop you getting infection. And again, the problem is there is confusion in the ranks now, isn't there, about, well, if I don't have to wear a mask outside, why do I have to wear one here?
Yeah, thank you, Hugh. We've had some questions actually regarding masks. Shabir Harun asked whether all health workers should be wearing FFP3 masks on NHS sites. And I know, of course, we've had recent news from the BBC that, in fact, not all the masks that have been given to health workers were of the protective level that they were meant to. That was headline news yesterday. What are your thoughts on mask and the FFP3, bearing in mind that the valve means that actually the wearer is emitting their breath, as it were?
Well, my feeling on this is personal. So I don't want to feel that I'm representing my trust, which I'm not, or my university, which I'm not, or the Intensive Care Society, which I'm not. This is entirely a personal view. My personal view and the way I practice is that I think we should have FFP3 masks on. We know that they are highly protective, very, very, very protective indeed. And I've been in the luxurious position of living on an intensive care unit where we knew that everyone had COVID. And in fact, the risks may have been a lot less than we thought, because most of them were intubated anyway. And as you weren't getting accidental disconnections, we probably weren't chucking out huge plumes of COVID at each other. The thing that made me much more anxious was going to the emergency department or onto a ward that was a non-COVID ward to see someone who had no idea if they were sick with COVID, or if they were coughing it, breathing it, or whatever else. And we know that breathing silently releases droplets and aerosols. We know that talking dramatically increases the amount of aerosol. We know that shouting or singing really puts it through the roof. And we all know that you can't go to a ward at 1 a.m. without someone being shouting for something. And in fact, shouting and singing, as you know, increases the aerosol load by up to 97-fold. Not 97%, but 97-fold. That's why I still think that patients should be wearing surgical masks, because we can't give them all N95s as a step down from FFP3, but N95s reduce viral load by around 90% and a surgical mask by about 74%. So I think getting patients who come in out of politeness to wear a mask, that will drop them by 74% if it's a surgical mask. And if we wear an FFP3, that makes it very unlikely that we will contract coronavirus SARS-CoV-2 or get COVID-19 from work if we alcohol gel our hands. I personally I don't nick them from the hospital. I buy them at exorbitant expense off online sources for FFP3s, but that's what I wear while I'm out as well. And that's all about making sure I can't give COVID to someone else if I do have it, but it's also making sure that I'm fit for work and that I'm not going to get poorly and be unable to attend my work if I do get COVID despite my double vaccination. So that's my view. I don't want to get COVID. I don't think it'd be good for me or my patients. And I think the best way of protecting myself in a hospital and outside is with an FFP3. That's my personal view. And that everybody should be wearing a surgical mask in an area where they might transmit virus to other people.
Thank you, Hugh. That's very clear. In regard to the Delta, really, are we in a strategy of herd immunity to the Delta virus? And how does that relate to what we were discussing earlier about other viruses, typically autumn winter viruses, but happening now?
It's a very tricky one, and we don't know, of course. If you get a coronavirus, most of the other coronaviruses will give you immunity. Let's think of the common cold versions, will give you immunity potentially for, let's say, 150 days. So let's call it 5 months. That would be about right. We know that if you maintain that buzzing around, as you say, you can suppress transmission and keep it bubbling along, which is why we're not all generally utterly flattened with RSV or common colds every single winter, although it does seem to me that I am quite often. We don't yet know about the longevity of protection from having been infected with SARS-CoV-2 or the longevity of protection that we're going to get from the vaccines. You can measure the antibody levels, the neutralizing antibody levels, those that are acting against the receptor binding domain of the spike protein. But of course, that doesn't tell you necessarily about the T cell immunity you've got, the T cells being those cells, as you know, that recognize a viral infected cell and go and nuke it and say, well, we know you're in there, you terrorists, so we're going to blow up the house. And that's what T cells do. And it's much harder to measure those sorts of immunity. But from the evidence we've got, which largely, and we've had data from Israel and we've had data from Brazil and a little from Finland, is that you probably are not completely protected by having had the vaccine. So Denmark looked at comparisons of 2 waves. So they saw people who'd been infected in wave 1 to see what happened with wave 2, which of course they couldn't adjust the timing for. But they reckoned that you got around 80-ish, 80 to 85% protection against reinfection in the second wave, which was 5 to 6 months later. In other words, a fifth of the people who got infected before could get infected again. That was worse in us oldies. So I'm not quite 65 yet, but the protection was about 47. It was 47.1% in those people at 5 to 6 months. The UK Siren data would sort of match with that. They reckon you've got about 83% protection at 5 months. So we will need to get some level of herd immunity achieved either through rolling infection and or with vaccination. And of course, the ideal is vaccination. If we can get everybody vaccinated, then we know that it's be harder to contract the virus, but we also know transmission is very, very much lower. The vaccine, even if you get sick, it makes it much harder for you to infect other people. So I'm not aware of the studies that have measured viral load, but we do know from the Israeli data that you're around 70% less likely to infect a household member if you get SARS-CoV-2 when you're double vaccinated, when you're double vaccinated, than you were if you just got it when you were in an unvaccinated state. So yes, we will need some level of immunity across the population, call it herd immunity if you will, but it'd be much better were that achieved with as close to 100% adult uptake for the vaccine as we can achieve. How we achieve that now, I don't know, because you will probably have heard from PHE today what the current vaccination rates are per day, but they're woefully low. And when I talk to friends of mine who work in vaccination centres, I spoke to one who said that she was there on Monday and they had 92 booked slots and they had 8 people turn up. Dealing with a recidivist rump of people who are the ones who decided that COVID isn't a problem, or it's you, Claire, I know, working with Bill Gates, having designed that evil chip that we're injecting into people. I don't quite know how we change that narrative at this point.
So this relates to a question from Paulina Sparks, who asks, will this new herd immunity plan of letting COVID spread unrestricted amongst the unvaccinated young, the youth, create a long COVID generation? And in fact, that relates also to a question about those that are double vaccinated and still get COVID now, the Delta version perhaps, and might they still get long COVID in those circumstances?
Well, the answer is I haven't got a Scoobies, but yes, there is that risk. And we don't know, quite simply because we still, and I'm on a grant relating to this, or a study now relating to this, we actually don't know what long COVID is. You and I think have spoken about this before potentially, but long COVID is syndromic. It's not a disease. It's not like a hemorrhagic stroke. It's a set of symptoms, and there are more than 50, some of which are variants of other symptoms, listed. So people probably have a mixture of different symptoms. And if you took something like breathlessness, well, breathless could be neurogenic, in which case it could be central peripheral, or it could be chemoreceptor, or it could be pulmonary. And if it's pulmonary, that could be fibrosis, BOOP, some other form of organizing pneumonia that's steroid or not steroid responsive, fibrosis, thrombotic, embolic, or it could be your heart, or it could be that your muscles are so knackered mitochondrially that you've got a low anaerobic threshold, and that's making you breathless. And that's just one symptom, could be any or all of the above. So given that we don't yet know what causes it, we're not going to know how long it might last. We do know that some people are chronically infected. There's been one paper out looking at gut biopsies many months, I think it was 4 to 5 months after infection, and nearly half of people still had actively replicating virus in gut after having recovered from symptoms, actually. So there could be part of that. It could be partly chronic inflammatory. There's some very good data coming out from Altman's group looking at autoimmunity as a function. And then we've got all those other things we've talked about, cardiac and respiratory. So there's a very long-winded way of saying long COVID is real. It's prevalent. It may be north of 1 in 50 people. For some of those, it does seem to go on for a very long time. And we will both know people who are still ill. I've got one colleague who's now 14 months in, who still cyclically every 6 weeks or so is getting temperatures up to 39.5 and is absolutely flattened for a week and then picks up again. So we will see this. Whether it will happen in children, I don't know the prevalence in children, actually. I've not looked. But there are certainly plenty of cases of it there. And it is a risk that we run, I think, yes. And we don't know what to do about it.
Thank you, Hugh. I do want to get on to lateral flow tests and isolation as well as mutation, but there's a question that's been upvoted 14 times. Professor Montgomery said we will never go back to pre-COVID life in his lifetime.
Yeah.
What specific measures is he referring to? For example, does he think we will need social distancing and masks, etc., forever?
That's a good question. And I think, well, of course, I thought the question you were going to ask me was how long do I think my lifetime is going to be? And it probably won't be that long. Yes, I think we are going to remain cautious about the way we behave, whether that's mandated or not. I can't envisage a time, unless this virus suddenly mutates, down-regulates itself to becoming nothing much more than a common cold, which might happen. I mean, it would be very nice if it did. But unless it does, I can't see the occasion when I'm going to want to be crammed into the pub shouting at the rugger in the autumn internationals or the Six Nations in the way that I used to. And that's a shame, because I used to very much enjoy the pint in my hand and shouting at the television set. But I won't be doing that. Now, I appreciate that if you're double vaccinated in 18 or 19, and if we find the long COVID risk is relatively low, maybe you will do that. But as I'm in my 60s, I won't be doing that unless this virus radically changes. Do I think we will, and a very personal view, should continue with mask wearing? Yes, I do. But let's think of how much that's been absorbed as a norm across Southeast Asia. I mean, I'm not alone, I suspect, in raising an eyebrow all those years ago, in the last 5 or 10 years, of seeing any Southeast Asian person on the tube wearing a mask. And I always thought, well, how ridiculous is that? But of course, they'd experienced runs of MERS and SARS-CoV-1, and they'd been there before us. And for them, it had just become yeah, well, that's just sort of what you do, isn't it? Remember 20 odd years ago, how often did we drench our hands in alcohol gel in hospital wards and wash our hands as well as we should have done? I put my hand up. I didn't do it as well as I should. I really do. The last 20 years, I absolutely have. That's become the norm. And it will remain the norm for me to carry, as I do in my pocket here, my little tube of alcohol gel, which before I ate my sandwich, I just slapped on the way through here. And I will continue to do that. So I think those sorts of normals remain. I think we will hopefully, I know our weather's not allowing it greatly, but try to live our lives a little bit more outdoors than we did indoors in large gatherings. So I think, I'm not talking about punitive restrictions here in mass lockdown, but I think we will be living with those common sense public health measures for a long time. And let's just reframe this. Let's just imagine if we were told there was an awful lot of open TB around. Would we really all be going around without a mask and taking a bit of care? Of course we wouldn't. We'd all be going, well, there's a lot of open TB around. We'll be a bit more careful.
I've got a specific question here that's been uprated from Gerard Latung. My apologies for pronunciation. Should elective surgical patients, whether vaccinated or not, be required to isolate before admission? And in your view, if so, how long for? I realise you don't write these guidelines and it's a dynamic field, but so do you have a view on that?
Well, I've got a sort of uninformed, as it were, non-expert view. I'm not a public health person or a virologist, so you should take what I say with a complete pinch of salt and consult an expert like you, Claire. I think the issue there is really that of what's the risk to a person who's coming in if they happen to have COVID. Well, if they're not ill with it, then at that point, the risk is relatively low. And unless they're having a major surgical procedure where suddenly getting your COVID, I don't know, think day 3 when you're still on a ventilator after a complex cardiac condition, that would not be a good idea to get COVID pneumonitis, would it? nor would it be potentially a good idea to go and, to be sick in hospital when you're having some other intervention, let's say chemotherapy that's going to destroy your immune system if you're already infected. So I think there are reasons for intense caution that people would be put at risk were they to have a surgical procedure, let's say, where coincidental COVID at the same time would be a bad thing. And I think that's more a common sense issue. If it were me coming in for a major procedure of that sort, I would want to make sure that I didn't get COVID at the same time. And I personally would be taking a lot of care to make sure I wasn't putting myself at risk. Then there's the risk to the staff. Well, we've sort of covered that. I think we have to take a bit of responsibility for that. And the evidence is good now that if you alcohol gel your hands and you wear your FFP3 masks, you really are very, 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 very well protected. So the risk to surgical staff, I know where we are with the current guidelines, and please don't think that I'm going against them. I stick with absolutely everything that's in those guidelines, but I think we are going to have to move to a case where you can protect yourself very well if intubating a patient, for instance, even if they have COVID, if you're wearing the appropriate personal protective equipment. And I don't think that necessarily needs to be water repellent, long sleeve gown, so forth. I think the masks and goggles and things work very well. And then the final risk then comes to your ward staff. Well, we've covered that too. That's masks and treating everyone as if they've got it, and the patient wearing an N95, wearing a surgical mask. And then the final bit is the risk to other patients. And I think that can be minimized, again, if all patients are wearing surgical masks, for instance. And if they're in the green pathway, your concern, isn't it, is that you're just dropping a fox into the chicken coop, that you've got one person with bad COVID amongst all the people who have not. This is where the testing comes in. I think testing done well is pretty good, actually, at detecting people with transmissible loads of virus. And it doesn't necessarily, I don't think, I know there's the PCR is the gold standard, but I don't know if that's something we should talk about, really, the question of lateral flow testing versus...
Yes, can we move on to that? So the health, both for the general population, but then whilst we're on it, specifically for our health workers, that balance, well, lateral flow and not isolating.
Right, so there's, the first thing to do is to talk about PCRs, and PCRs are polymerase chain reaction amplification. So you essentially take a bit of viral RNA, you turn it back into DNA, and then you copy it once, and then you copy all of that again, and then you copy that again. So you go 1 strand goes 2, 4, 8, 16, 32, and you do a number of cycles where you warm it up, cool it down, and let these double up. And you can therefore detect very, very, very low copy numbers potentially of the virus. And this cycle, thermal threshold cycling, comes in numbers. So I know you know this, but I'm not saying this to you, just in case there are those out there that don't know. So a CT value that's low means you don't have to do many cycles to find the virus genome. So there's lots and lots of it there. So a CT value of, let's think of something bonkers like 10, you're really full of viral RNA at that point. A CT value of about 40 means that you really haven't got very much there at all. So you're pretty unlikely to be infectious if you're up in that sort of range. And symptomatic people tend to have CT values of less than around 25. So if you get a positive PCR, it could, if it's, let's say, a CT value of 10, you're actively infected and you're actively infectious. And whether or not you're feeling ill, you're a risk to other people, and that's V bad. If you've got a CT value, let's say, of 35, it could be that you're just on the way up and you're in that sort of 40 hours of mounting infection before you get sick, bad. Or it could be you're on the far side of it. You've been through a period of being ill, symptomatically or not, or infectious, and you're actually now on the mend. So you need to track where that value is going. And those are sensitive. The question then, but they take time and they're costly and they have a long reporting lead time potentially. Whereas the lateral flows, of course, we can all do at home, and a lot of us on this call will. Now, the sensitivity of the lateral flow depends on two things. It depends on how infectious you are, which depends on the CT value. So if you've got a CT value of less than 25, a lateral flow done by a medical professional is pretty much 100% sensitive. It will be as good as a PCR. If you've got ragingly high copy number, it's going to show up. If you, in general terms, if you've got a CT value of less than 25. If you've got a CT value of 30 to 35, which could be on the way up or it could be on the way down, you're around 44.8% sensitive. And if your CT value of 30 to 35, which is greater than 35, so much lower copy numbers, its sensitivity is nearly only about 1 in 5. It's 22.5%. Now, what that means then is if you've got a positive, it's a positive, and you are infectious and a risk to other people, and you shouldn't be going anywhere near them. And you don't know where you are, whether you were going to be an asymptomatic person or whether you're still on the way up. But either way, you should be isolating yourself for the full whatever day your Public Health England people tell us now, 12 or 14 days or 10 to 14. If you're the problem with screening as a one-off is, let's suppose you've got a CT value above 35. In other words, you've got viral RNA, but you've got a 4 in 5 chance you won't detect it on the lateral flow. You then have to do it again and again and again and again to find out whether you are infectious. And how you apply that depends upon the risk for you as the patient and the risk to the people you're exposing yourself to. So across population screening, it might be that a couple of times a week is just fine for people coming into work in a workplace, because you are trying, let's suppose, talk about film lots or whatever, or a big banking sector. What you're trying to do is minimize, take out the majority of infectious people so they can't infect people. And you will pick up the majority of infectious people. There'll be the odd one who's negative today, who's going to be positive Wednesday lunchtime, and it's just going to slip through, let's say. But you will mop up quite a lot of them. If you've got critical infrastructure, you absolutely want to know every day that person is not infectious. And that, of course, is the case for things like, in my view, being admitted to hospital for major procedures. And that's why you get a PCR or some other form of test the day before or the day of admission, because you could have snuck through, if it's a lateral flow, without knowing. A PCR is going to pick things up much more with much greater sensitivity. So the answer is, it depends on where you are as in the infectious cycle, what you're doing it for, to get population prevalence or to safeguard a workplace, and what the implications are if that one person breaks through. So if you think in the film industry, you want to protect the principal completely, because if the lead actress or actor becomes ill, then you've just toasted hundreds of millions of dollars of budget. That means you really need daily testing for everyone who might be coming into let's say in intimate scenes where they can't wear a mask. You really do need to make sure on a daily basis that every single day that person is not in the CT values that might put them at risk. So there you are. That's the view on lateral flows. My view on lateral flows. It may not be the right.
I think that addresses the question that we've had, for example, from Sangeeta and Unangat saying, with her health workers doing lateral flows rather than self-isolating. In your view, if they're doing it daily and otherwise don't have symptoms, that would seem to be reasonable in your view?
I think it would be. And of course, bear in mind, this is like any military strategy for protecting a sort of a key asset. You don't just put some anti-aircraft guns up and say that's enough. You've got razor wire and guards and a whole bunch of other things too. And if you are wearing your FFP3 mask properly in the hospital and alcohol gelling, and your patients wearing their mask, you know what? If you've got a false negative because you've got a CT value of, let's say, 25 to 30, where 1 in 5%, 1 in 20 false negatives, then there's a 1 in 20 chance to be infected with that. We've got that CT value that you'll have a negative test. You're still not going to give it to anybody if you're wearing the mask properly and you're behaving sensibly and keeping your social distance, not packing out your canteen like a penguin colony.
So Hugh, we are going to, I'm going to allow this to run over, if that's all right with you, and that you're okay with time to do that?
I am. I will have to dash shortly because I've got to go and do a briefing somewhere else. But the last thing to say on the lateral flows quickly is, of course, it also depends on who does the testing. And there's very good evidence that if you let people self-test, they're much less good at doing it than when someone does it to them. And that's because you or I will be brutal to someone else and we'll poke that swab where it hurts and we'll give it a proper old wriggle around. And people doing it to themselves very often, it turns out, sort of tend not to do it quite as effectively. And in some studies, you can lose 30% of your positives by people not doing it well. Some in Israel and others have tried to overcome that by making you video the test and using AI and analysis of video. It's saying, yes, that was done correctly and that was you, and we can link that to the negative test that you're now showing us.
Extreme measures there. I've got a question here which really is a great one for you because of your sort of technical and pathophysiology understanding in regard to it's from Sangeeta. Have you come across other viral infections causing prolonged systemic inflammatory similar to post-COVID inflammatory response? How much does this contribute to other autoimmune disease? And long COVID is very much like other autoimmune responses.
Yeah, I don't know is the answer. It's a very interesting question because I suppose we've had, I suppose the one that we're all familiar with, of course, would be Epstein-Barr virus, where we see people who feel totally fatigued for a very long time. And to my knowledge, that's been largely inexplicable. Someone might know the answer on this call. I've not looked up the data to find out what's been driving that, but that certainly is a real thing, isn't it? Whether or not, whether the degree to which chronic fatigue syndromes are post-viral, or classic CFS, I don't know. My suspicion it's a mixed bag of causes again. But I think it is going to require us to revisit the causation of some of these long-term states. And it's going to be a very complicated issue. It won't be as simple as just detecting an antibody that we already knew was there, then sort of looking for the known unknown. A lot of this autoimmune work that's been going on at the moment has had to take a very, very agnostic approach to say, let's look at a whole raft of human epitopes and see whether we can find antibodies that bind to those things. And turns out there are a lot of them, actually, that this massive inflammatory response we're kicking off with the virus is triggering an awful lot of autoimmune, a lot of antibodies. There's also this whole business of the gut microbiome, which, years ago, I suppose what most people knew about that was a Yakult advert on telly. But the gut microbiome now, we know, has very, very important roles in a whole pile of things, but one of which is the regulation of the systemic inflammatory response. And that's not to say your gut gets inflamed, which makes you ill. This is a powerful organ of regulation of your immune system. And we know that ACE2 is expressed in the gut. We know that one of its roles is regulating the gut microbiome. We know the gut microbiome does change with SARS-CoV-2 infection. We know that a lot of people, or some people at least, get chronic viral expression inside gut. So whether we are dysregulating immune system from gut level, I don't know. I'm purely speculating here. So it's a long-winded way of saying I don't know the answer to the question, but I do think we're going to have to start looking in a lot more detail, firstly at SARS-CoV-2 and long COVID, but also how it relates to other chronic illnesses, not just fatigue.
I'm just going to divert just to read out to you from Renu saying, thank you so much for this session, greatly appreciated. And Nicola Davis saying, how can I download the transcript, please? I think the richness of your answers is being greatly appreciated. I want to just ask about mutations. So we had a question from Dr. Sultana Khanum. Being exposed with Delta variant, is there a danger of having a new mutation and a new variant?
Yes. So we've seen this already, of course, with that's why we've had the Alpha through Delta and ongoing other variants. So this virus will continue to mutate. Bear in mind, every cell it infects, it generates, each virus that infects a cell will generate another 100 copies of itself as a minimum. So, we are going more like 1,000, in fact. So, and there's always going to be transcription copying error. So we will get these sorts of mutations and they will continue to roll on. And in fact, we've seen this in other situations. Now, the frequency with which you get something nastier cropping up varies. If we look at SIV, simian immunodeficiency virus, which was probably the precursor for human immunodeficiency virus, HIV, best guesses as far as I can see are that it probably crossed over into humans sometime in the 1930s. But it was probably a low-grade infection that wasn't desperately dangerous to humans, but at some point it mutated. And then in the 1980s, we ended up with this massive problem because the mutation had appeared. And we have seen a lot of gain-of-function mutations in this virus already, the Delta being a classic. The Delta variant's got at least 7 very unique mutations in the spike protein alone. Several of those, well, 2 particularly, 452 and 478, do seem to change the antigenic nature of the spike protein, which means that it could affect vaccine efficacy, which may be why these vaccines are, I think, fairly clearly slightly less effective against Delta than they were, for instance, against the Alpha or Kent variant. There's one, the Pims 681 at the S1 cleavage site, which gives you higher replication. So the answer is yes, we've seen it before and we will see it again. And this is the problem. When you hear these talks about we're not safe if being vaccinated unless everybody is, that's to some degree true, because you just got to damp down the transmission and viral load. But even then, we are still going to see new variants appearing.
And related to that, I just wanted to raise the issue that some people feel very strongly that in easing restrictions now is giving the perfect scenario for vaccine escape. And following on from that is the data, which is not yet published, as I understand it, from Israel, which is that the Pfizer vaccine is considered to be waning in its effectiveness. Any thoughts on those issues?
Well, of course, as you say, those are unpublished. Well, they're not published peer-reviewed data yet, but that's the signal that seems to be there. And of course, this is no more than you would expect. If you apply an evolutionary selection pressure to a virus, nature, as they say, will always find a way. So if you start pressing in one direction, it will find a way out of it, just as we see with antimicrobial resistance, which is a totally different thing, but is the same thing. You apply a pressure on the bacterium and it will find a way of getting around it. So and I think that's right. The scientists know far more about this than I, of course, wrote that open letter of well over 100 a week or 2 ago now, saying, look, there is a real danger to this. You are lifting the lid when you've still got the numbers we spoke about earlier on that are not doubly vaccinated. 11+%, more than 1 in 10 aren't vaccinated at all. And you've got a huge number of people that aren't vaccinated at all who are below the age of 18. So we are indeed, I think, running that risk of letting it run wild. Now, it's not to say that whoever's in government and making these scientific decisions that I want to criticize them, because they have access to information and modeling that I don't. And I was wrong. I was expecting 100,000 cases a day by now, and we haven't got them. But I do think it makes a very strong case for that if we are going to lifting at the moment, it is beholden upon all of us to still behave responsibility as individuals and to be very clear in our communications to our friends and colleagues about why that remains a sensible thing to do. I think it's also, on another issue, our responsibility to call out healthcare colleagues who spread disinformation about risks of vaccines. And I was horrified in speaking to 2 colleagues, or 2 friends rather, in their 70s, who went for their 2nd dose of vaccine only recently, were very pleased about it, but said that the GP nurse that gave them the 2nd dose said, well, I'm glad you're getting yours, but if I was 21, I wouldn't be having it. And they said, why not? Oh, because I want to have children. And this promulgating these stories that vaccines cause infertility and so forth, I mean, I think it's prevalent. I know trusts where very large proportions, particularly of female nursing staff, are resistant to being vaccinated. And it seems to be because they're getting this disinformation coming through Twitter feeds and Facebook pages. And I think if we hear that being spread, we do need to gently put a stop to that.
Can I just raise one thing? And I'm going to ask if you can reply within a minute, if at all possible, Hugh, which is in regard to the AstraZeneca viral vector and future boosters. I know that there's a hope that there's going to be able to work around this, but could you just clarify your thoughts on this for the benefit of the audience?
Yeah, well, I don't know the answers yet. I mean, there are some unknowns here. There's the first question about whether mixing vaccines is good or bad. The signal at the moment that you'll be aware of is that it's probably good, that actually having a mix of vaccines may actually have some benefits, particularly to T-cell, longer-term T-cell immunity. So I'm not telling everyone they should. I'm not saying if you had Pfizer last time, ask for Astra this time. That'll be your job in PHE to tell us what to do. But that's the signal that seems to be emerging, that it's certainly not dangerous, it's certainly not inferior, and that there may be some benefits to having a mixture. Now, the question then is about viral vectors. And again, I don't know the information. In theory, using viral vectors, you've got to watch out for the fact that you don't get immunity to the viral vector. Because if you've got an immune system primed with lots of antibodies that would mop up your next dose of vaccine, then that is a potential, in theory, problem with recurrent use of the same vectors. To be clear, there's no evidence at all of that happening with dose 2 of any of the vaccines that use a viral vector, but it's a theoretical risk. And then the final question is the redesign of vaccines if we do get vaccine escape. And that's a very interesting question. And so we know, of course, that AstraZeneca were trialing the next version of the vaccine that was more selective against the South African variant. But of course, we can't be fighting a war where we're always chasing, because we'll come up with a response to the new version and there'll be another new version before we've got the first one tested. And that's going to be an interesting challenge. I don't know how one cracks that. I think there's been an awful lot learned about vaccine design, which will allow very, very much more rapid constructs, whether it's an RNA vaccine or a vector-borne vaccine, to be specific against new variant if there is escape. But it will be down, I think, to a large degree to the regulatory authorities to determine how quickly they can allow testing for those, or whether we have to stick with the same old path, which might be many, many, many months of testing to prove safety. You could argue it both ways. You could say, look, it's got a slightly new construct, therefore it's a new agent, needs to start completely again. Or you might say, look, it's the same RNA and the same stuff and everything's the same except for that little segment. And we're going to lower the bar for safety trials in those sorts of groups. And thank God that's not my responsibility to make those decisions, but those are the challenges coming down the pipe.
Hugh, thank you so much for that answer. And what I think we take from that is watch this space. There's work being done. And I know that you're involved in a number of these trials. And we'll be looking at these issues over the months ahead on this webinar series. Just bear with me, Hugh, if you can, whilst I do some announcements. The team are having our break from our regular In Conversation series next Wednesday. My apologies, but you've all got a night off for those who are regular watchers of that series. I know many of you are, but they will be returning to our screens on the 11th of August. With an In Conversation with Professor Parveen Kumar. It will be a wonderful episode. She's a previous president of the RSM and has a lot of huge achievements in her career, but also interests in climate change and global health. And I look forward to hearing that. Next Wednesday, our regular Thursday COVID webinar, same time as now. We have an episode looking at the impact of COVID on health inequalities, something you raised earlier in this webinar as a priority area. We're doing this in partnership with the Health Foundation, and we have Professor Michael Marmot chairing that session. We have further ahead on the Wednesday, the 22nd of September, it's part of this COVID series, but it's specifically looking at vaccines, variants and infection, the position this winter. We may be able to give you some updates on some of the issues that we've discussed with Hugh today. It's an extended episode. We have Professor Dame Sarah Gilbert, who's just received the gold medal from the RSM on Tuesday of this week. Huge congratulations to her and her achievements. We also have Professor Sharon Peacock and Professor Sarah Walker, all eminent authorities on these issues. That will be followed by a panel of clinicians and public health experts who will be discussing our systems and services and how we're going to manage our health service for the forthcoming winter. So hopefully of interest to everyone there. That episode is now available online to register, and please do. I obviously am so grateful to everyone who has donated to this series. It allows us to continue it. For those who are interested, a page will come up at the end. Please do donate a small amount, a large amount, whatever you feel comfortable, does allow us to continue this series and develop more series that are relevant across all of the specialities in medicine and surgery. And last and most importantly, Hugh, it's an absolute pleasure to have you on this webinar. It's an absolute pleasure to have you again after last time having this one-to-one with you on the third of our series, although of course you've contributed to other series along and through this whole of this last year. We're grateful for your time, your insights, and many of the comments have reflected that from our audience. Thank you.
Thanks very much for having me. Thank you. Stay safe, everyone.
Yes. Bye-bye.